PNOC Foundation. We're so glad you're here today for this informational webinar focused on DMG and DIPG, some of the most aggressive and difficult to treat pediatric brain tumors. For those of you who are joining us for the first time, the PNOC Foundation exists to support the work of the PNOC Scientific Consortium, a collaborative network of the top children's hospitals and researchers working together to accelerate breakthroughs in treatments. Our mission is to urgently raise funds, resources, and awareness to support PNOC's research and clinical trials, and to ultimately improve outcomes for all children with brain tumors. One of our main goals is to make sure patient families have direct access to the latest information straight from the people leading the work. Today's session is all about what's happening right now in research and clinical trials for DMG and DIPG. We're incredibly lucky to be joined by a panel of world-class experts, the true dream team in the field. Leading things off today is Dr. Sabine Mueller, PNOC co-founder, scientific lead, and pediatric neuro-oncologist. Dr. Mueller, I'll turn it over to you.
Great. Thank you very much, Adam. And thank you everyone for joining, and especially great thanks to my panelists, Dr. Nazarian, Dr. Koschmann, and Dr. Prados. So we prepared some slides, but please feel free to enter any questions into the chat. We will monitor the chat, and then we can also hold the presentation. We want us to be as interactive and informative to our audience. So I'm going to share. Great. So first of all, we obviously wanted to thank all of our families and patients who continue to enroll in our clinical trials, but also support us to fundraising, creating awareness. Without all of your support, really none of this work would be possible. What we wanted to highlight first is really a wonderful resource, which was initiated by many families and is currently funded by the DDRFA, which I know is supported by many foundations really across the US and also internationally. And this DIPG DMG National Tumor Board basically allows us to review with experts really across the country to review cases. We review the images, we review the molecular alterations if present, and then we send reports to the treating physician highlighting current potential trial options for each patient. And we have had really wonderful feedback from our families, from our nurse navigators, from Chat Tufty Feed DIPG, but also from the families and treating physicians. So if you know of anyone or if you are personally impacted by this disease, this is really a great resource to get expert advice from really key thought leaders in the field. So I just wanted to highlight this. And if you search it online, you will easily find this. But what this talk is today about in our presentation is really about a wonderful group of people with PNOC DMG Act. And Javad, I will let you take this.
Thank you, Sabine. It's been an honor to build the PNOC DMG Act working group. As some of you know, we started with 3 or 4 labs across the Atlantic, and now we are in 59 institutions, 14 countries. This has been really a model for many other diseases and entities that are now forming similar working groups, similar to DMG Act. One of the benefits of our group is that we share models, resources, data very readily. We've also worked with pharma, that the contract is typically made with University of Zurich, and then we share the drug with other institutions. That really facilitates the ease of having data and resources. But the best advantage of the group has been the clinical trial design, the correlate studies that we are collecting and analyzing, that we will highlight some in today's call.
Sorry.
One of the outcomes of our working group has been to collect all of the samples that we have from patients with diffuse midline glioma. You can see the breakout on the top pie chart. These are 49 patients with DMG, but collectively with midline gliomas, we have 60 patients plus 10 healthy, non-tumor oriented patients, collected brains that we have. And we have formed a tissue microarray. Essentially, a tissue microarray is punch cores of every specimen that we have collected. If you count the specimens that are within our tissue microarray, we have 913 cores that are now collected. We have used, some of you again may have seen some of this data, which is now pre-printed in bioRxiv. The barcode is in the bottom if you like to have access to. This is the largest collection of pediatric tissue microarray, pediatric brain tumors that we have collected now. and analyzed. We have stained this to look at biomarkers that are indicative of immune interaction of these tumors. The data is available. We are working with University of Bern and other universities across the US to build dashboards where all of the digital data will be available for our colleagues. On the left, you can also see that we have been initiated working on AI to be able to digitize and analyze the specimens that we have. One of the powers of the AI that we have again highlighted in the publication that we have is that the specimen that are stained or stained for a biomarker of interest can be now scanned, and we can, without any other analysis, we can really identify up to 22 different antigens or antibodies within the samples that have been now AI trained. This is a work in progress. Our goal is by the end of next year to have the majority of biomarkers that are important for immune, as an immune indications, to have them digitized and have them identified by AI. On the right side, you can see the dashboard that we are forming. Again, a number of our institutions are involved in this entity, in this effort. Again, the idea is that to have all of the digital data that we are collecting from patients, digital scans of the slides that we have available for anyone to analyze.
Great, thank you, Javad. And really originating by a lot of work from all the people participating in DMG Act, we then really worked very hard with Dr. Prados and Dr. Koschmann and also Dr. Klein and Dr. Frenzen, really on how can we then translate these exciting preclinical results into a really agile, adaptive clinical trial. And with that, we really formed the DMG Act platform trial, also called PNOC 22. And I'm just going to briefly walk you through it. And so basically, patients can enter this trial at 3 different stages in their disease journey. So newly diagnosed upfront before patients receive radiation therapy. They can also enter the trial post-radiation therapy, which remains the standard of care for these tumors. And then there's also an additional arm, cohort 3, where children and young adults can enter this trial at the time of recurrence when they're also eligible to receive a second round of radiation therapy. And based on a lot of preclinical and clinical work by key members of the DMG Act team, we started this trial using ONC201, which is an oral available metabolic targeting agent, and with another agent called paxilosib, and this is based on data that the combination of these two led to really promising results in preclinical models based on a lot of work from done in Australia. And so then children are getting randomized to receive one of these agents during radiation therapy, and then they basically, all the patients receive a combination of these 2 agents in maintenance. And then when patients haven't had a biopsy yet, we perform what we call sort of a target validation, or sometimes we refer to this as phase 0 study, where children take one of these medicines just 24 hours before their scheduled biopsy. And then we can basically, looking at the concentration of these medicines in the resected tissue, which really allows us to further define sort of the CNS penetration of these agents. And showing here is just a slightly different view so that you understand the design. So it's really newly diagnosed pre-radiation, post-radiation, and at time of first progression. These are the 3 different cohorts. In each of these cohorts, there's, like I said, there's tissue-based assessment. Everyone gets radiation, and everyone gets the combination with ONC201 and paxilosib. And the trial is designed that they can easily add in new combinations into the trial. And initially, we also had the combination of ONC201 and panobinostat, but unfortunately, then the company providing panobinostat couldn't support this trial anymore. But I think what is really exciting, not just the design that we can rapidly advance preclinical findings into the clinic, it's also really the breadth of correlative studies we have built in due to the really great work and collaboration with our preclinical scientists as part of DMG Act. So we are now collecting cerebral spinal fluid on these patients at defined time points. We are looking at cell-free DNA. We are looking at different blood biomarkers. We are looking at PK, sort of how a body is metabolizing these agents. For every child enrolled in this trial, we are also collecting tumor tissue, allowing us to really identify specific mutation in each tumor, and that might help us to really predict who are the patients responding better or less good to this kind of therapy. We're also collecting microbiome, which I will highlight a little bit later. And then obviously we have imaging performed every 2 months. And so just, Javad, did you want to say?
Yes, I was just going to interject.
Yeah.
I just want to highlight this for the team as a scientist. This is super exciting. I think the collection of the biospecimens that we have longitudinally for every patient within this trial, the type of specimens that we are collecting is such a fantastic resource, and it gives us a better visibility on how the tumor or the drug is working. And Sabine will highlight some of this. But this is very unprecedented in many when you compare to other trials. And Carl and I and Matt and Sebastian and others who are working on this, we are very excited to analyze these cohort samples and put it in context of trial and hopefully understand better about the response of these patients.
Yeah, thank you, Javad. And so, and I think really what I want to highlight here, and this is really through the dedication of all the teams in our PNOC network, especially also our international colleagues. So these first 3 cohorts where patients receive, as I mentioned, the combination of ONC201 and paxilosib. This trial is now open at 31 sites and internationally open, including sites in Europe with the Princess Maxima, sites in Israel, sites in Zurich, but also in Australia and obviously in the United States. So I think that's a big achievement really to the PNOC operations team, but also to all of our PIs and at the local sites pushing this through. This was not an easy undertaking. And so really, as you can see here, really in record time, we enrolled a large number of patients in these different cohorts. And as expected, we enrolled more patients in cohort 2. As mentioned, we had 1 patient enrolled in the combination of ONC201 and panobinostat before we had, unfortunately, to close that arm due to unavailability of panobinostat anymore. So then using all of this data and looking at really the tumor biology that we enrolled in these in this trial, we can see here, and this is really a lot of work by Sebastian Borchak, who is looking at all the genomic detailing that also has been performed at the University of Michigan. But we see that obviously all of them basically are these H3 K27M altered tumors, and this is here split by cohort. And then as expected, we find also in this trial population key alterations that we were aware of that they occur in the context of these tumors, such as TP53, ATRX alteration, MAP kinase alterations, as well as PI3 kinase pathway alterations. And really this type of analysis, and we are just in the midst of this, will really help us to understand, are there any molecular predictors that will help us to differentiate amongst the patients who will have a better or worse response. And just highlighting you some of the responses we've seen, I just wanted to put our trial outcomes into the context of more recent studies that were completed by the St. Jude's Hospital by Chris Tinkle, where the overall survival really was stagnant at 11 months. And then there was also a recent publication from the Pediatric Brain Tumor Consortium by Dr. Baxter, looking at a combination also of more traditional chemotherapy, where the overall survival was around 11 months. What I think is also important to highlight that really in the past, the historical control really, we've seen really that really none of these patients survived. And I think this is where we're starting to see shifts within the whole field of diffuse midline glioma clinical trials. So what I'm highlighting here is now the outcome of based on overall survival, based on these different cohorts. So this is cohort 1, newly diagnosed. And what we are starting to see, we are starting to see on the current trials really that we start seeing a tail, so that we really have some patients that what we call sort of long-term survival. But obviously here, the median overall survival was 13.1 months, so maybe slightly better than compared to historical control. However, there's obviously a lot of work ahead of us. The same on cohort 2, we often now see sort of often reported sort of median overall survival in the current studies for us was 15.6 months. But again, we see a tail where some of these patients seem to be definitely living beyond 2 years. And then in our last cohort, these are patients entering this trial at time of recurrence when they're eligible for radiation therapy. Our median overall survival from time of recurrence is 8.7 months. And again, we see sort of a tail end here where some of these patients are now greater than really 4 to 5 years out from initial diagnosis. And so that's telling us that obviously there's some biology driving the better survivors, but there might be also signals in here why some patients might respond better to the set of combination therapy with ONC201 and paxilosib compared to others. And we are really hoping to really over the next few months to be able to inform these questions so that we can then potentially build on this and define more specifically which patients should enroll into this trial. And so what we also built in here, and this is really wonderful work by the team at Michigan, we wanted to understand also how our patients and families do on the clinical trial in terms of how satisfied they are enrolling into this trial. And especially because we started to have this cohort 3 where children enroll at time of recurrence. And that was really lots of discussion with foundations and families. They really wanted to also have an option at that disease state, but we wanted to make sure that the sort of aligns. And what you can see here, I think, over time, obviously, patients remain quite happy that they participated, and obviously at the end of treatment, and that's often associated with time of progression, the satisfaction goes down. But overall, we were quite pleased that the satisfaction of our families enrolling into this trial was quite high. And so I just wanted to highlight one of the really exciting areas that we have seen emerging over the last few years, not just in cancer, but in many other diseases. And that's looking at the interaction of the gut microbiome and outcome of certain disease processes, such also as metabolic diseases, but we obviously will specifically focus on cancer. And so based on some of the data we have seen, that this is showing that the gut microbiome modulates responses to immunotherapy in melanoma patients. And there seems to be quite a difference depending on the composition of your gut microbiome. And so really in wonderful work with the team at the Children's Hospital of Philadelphia, Dr. Klein, and also the team at the Princess Maxima Center in the Netherlands, we then started to collect these stool samples on our patient at these different cohorts at different time points. And that is actually not an easy task. It was quite a lot to organize within an international trial context, but we got this accomplished. And I'm showing you very preliminary data for patients who enrolled on cohort 2. So these are the patients enrolling post-radiation therapy. And in our very preliminary analysis, and this is wonderful work really spearheaded by Raoul from the Netherlands, where we can see that depending how diverse the composition of a microbiome is from our children into this trial, that the ones who have a more high diversity class seem to do better in terms of progression-free survival, but as well as overall survival. And so now we are very excited that some of the foundations who might be also on the call really support ongoing work so that we can now extend from this initial preliminary smaller cohort of patients to expand to look at all the stool samples we have collected as part of this trial. So this is something we are aiming to really explore because there's also options to potentially modulate the microbiome and potentially intervene. So next I will let Carl talk about some of the exciting metabolic analysis he is leading.
Sabine. So as some of you may be aware from the data from the phase 1 trial, the multiple phase 1 and expanded access protocols, we had looked for signals and the mechanism underlying ONC201. And when we took it back to the lab, we found that ONC201 works 2 ways. One is by really disrupting metabolism, turning off the gas tank of these K27M cells, which they're very much need to be running at full speed, as well as shifting the metabolism in a way that actually disrupts the epigenetics that are key for K27M, leading to differentiation and restoration of this trimethylation mark, which is a really critical feature of K27. So we think it's those two, that double whammy, that actually makes K27M cells specifically targetable by this ONC201. When we did a small series, there was an arm of the phase 1 where patients got serial CSF. We not only showed that that was safe and feasible, but also that there was a signal of certain metabolites like this L2HG potentially correlating with response as being an extra biomarker in addition to MRI. And that kind of fit with our understanding of the mechanism of these. So with that in mind, when we built PNOC 22, we really built in this progressive structure where midline glioma patients were going to get serial CSF on study as moving into that closer to a standard of care is where we think this will be moving, because we know the number of biomarkers and the amount of information we can get there is just expanding. Go ahead, Sabine. Okay, so this is the preliminary data from patients who got ONC201 and paxilicib and received CSF or had CSF taken at multiple time points. And one of the things that we were interested to see was that some of the metabolites that we had seen in the phase 1 CSF data we're seeing again now in this larger prospective cohort. L2HG and glutamate being things we saw in the phase 1, we see in our cell lines. And for patients who have an increase in those at their cycle 3 CSF, so after 2 cycles, those patients have longer survival with ONC201 and paxilicib. So this is the prelim. We have another batch of samples. And I think moving forward, our plan is to continue to collect CSF serially for tumor DNA, but also for CSF metabolites like this. I think there was, I don't know if we're handling questions later, Sabine.
I think some of the questions we can maybe answer at the end, yeah. Okay. But if you see any that requires immediate attention because of the slide, then just let me know. So what is next for the DMG ACT platform trial? Through ongoing analysis, looking how children metabolize ONC201, there was definitely sort of results that we were able to see as part of PNOC 22, that especially the young children might require a little bit of a higher dose. And that's something we have seen over and over in pediatric oncology, that especially the younger kids, they metabolize drugs much faster than adults. So we are testing in cohort 4 for the dose escalation. And then based on some really interesting data for some of these alterations, looking at combination therapies, really through wonderful work also from Carl and his team, we now added sort of different, more molecular defined cohorts into the trial. So if a child or young adult has the H3.3 K27M mutation and also has a co-alteration of NF1, we then can prescribe now on the trial the combination of ONC201 and the MEK inhibitor. If you have a PDGFRA alteration, we use the combination with avapritinib. If you have a combination of BRAF V600E and the histone mutation, then we are adding these 3 medications. And then for FGFR with erdafitinib. And we now actually already closed sort of enrollment into the dose expansion cohort and are currently working on analyzing the PK data on this trial to inform further dosing strategies. And this cohort also is almost close to enrollment, except for the BRAF V600E, and currently undergoing toxicity evaluation and monitoring by the UCSF at DSMC. But we are obviously excited to really move forward very specific combinations based on each patient's individual alteration. But obviously, when we think of sort of the whole field of diffuse midline glioma, one of the exciting strategies that has been moved forward by many of the key thought leaders really in the field, looking at Children's Hospital in Seattle by Nick Ventanza, or Stanford with Michelle Mongi and many others. It's really about immunotherapy strategies that really also emerge as a very promising therapy to move forward for diffuse midline glioma, mainly looking right now specifically at CAR T-cell trials. And what we are moving forward as part of this platform trial is another form of immunotherapy, what we call oncolytic viruses. So we understand that there are very specific viruses that when you inject them into tumor cells, that these cause a direct cell killing effect. And in addition to causing this direct cell killing effect through the cell death, it's also causing an immune reaction. And so we are trying to utilize that type of approach to be integrated in the DMG ACT platform trial. And this is really based on great work by our wonderful colleagues, Marta Alonso and Jasper van der Lucht, who basically, they published this data in the New England Journal of Medicine now a couple of years ago, and they treated newly diagnosed patients with DIPG. These children underwent a biopsy. Then the tumor is injected directly into the brainstem, into the tumor. Then they undergo radiation therapy, and then they basically looked at sort of the key outcomes we would like to analyze in these early phase clinical trials. And what they were able to show is that overall, this was pretty well tolerated, that the overall outcome, the median overall survival was very encouraging with 17.8 months. And they had 2 long-term survivors, greater than 5 years. One of them, we have to say, didn't have the H3K27M mutation, but regardless, this is obviously very exciting data. And then there's a lot of other data supporting the role really of oncolytic viruses in the treatment of brain tumors. There's a recent indication that was approved by the Japanese regulatory agencies for glioblastoma. So we are trying to build on these exciting data. And what we have learned in our consortium, that actually repeated injections into the brainstem, and this is not oncolytic viruses, this is where we use sort of a strategy referred to as convection-enhanced delivery, where we put catheters directly into the brainstem and infused, the agent here was MTX-110, which is a soluble aqueous version of panobinostat into the brainstem. And the reason why I'm showing is that we were able to show that repeated injections into the brainstem was feasible and relatively safe. So by using these 2 data points, that we have an exciting sort of first single phase study with one-time administration of this adenovirus, the Delta 24 RDG as an oncolytic virus, and that we showed it was safe to do repetitive infusion into the brainstem, we thought that most likely this type of approach will be much more effective if we allow for repeated infusion. And so based on this, really, this wonderful team with Rebecca and Jasper being the study chairs, lots of surgical study chairs as well, because this is obviously a highly complex surgical studies. We are now moving this repeated infusion of this virus forward as part of one of the additional arms of our DMG platform trial. And so this is the rough outline. So we are stratifying by disease location. So we have the pontine tumors and we have thalamic tumors. And right now we are exploring this in the post-radiation setting. And we are looking specifically to understand how many repeated infusions or injections of this adenovirus can be performed and it remains safe. And if we meet this threshold, then we go into an expansion cohort to also understand the potential efficacy of this process. So here's just showing another sort of diagram of it. So patients will come into the trial post-radiation, and then basically when they enter the trial, Ommaya is placed, a biopsy is performed, and the virus is administrative. And then every month these patients return and we will give virus. And then a lot of discussion with different families, advocates, but also with our pediatric neurosurgeons. We then will take a second biopsy on cycle 3, and then we continue. And I think what is really what I really want to highlight here is that this will be one of the first trials where we can actually have access to tissue on treatment, which I think is still remains one of the limiting factors why we are not moving forward, having more effective therapies. Because we don't quite understand how these tumors change in response to any given therapy. But since we are injecting the virus directly into the tumor, we have an opportunity here also to collect tissue at the same time. At the same time, we are also collecting here each time sort of the needle wash that really Javad had explored early on, and really trying to understand how these tumors change, and if there's anything we can learn from is to further enhance this type of therapy. And I don't know, Javad, if you want to add anything here.
Yeah, I guess there's a question about the application of this therapy for patients at recurrence.
Yeah, so
Okay.
yeah, so we had a lot of discussions because I know families are always eager to participate. So right now, how the trial is currently designed, it is only in the post-radiation setting. If we see initial safety, then obviously we want to move this forward also to the other cohorts. So if you are newly diagnosed, but also at time of recurrence. But right now, this trial is testing the safety and how many injections we have only in the post-radiation setting. And as part of this trial, we obviously will collect the same amount of correlative studies as we've shown for the first 3 cohorts. Any other questions here? Javad?
Yes, there's also from Patrick has 2 more questions about when will the oncolytic virotherapy trial within the PNOC trial begin?
Yeah, so great questions. I would love it would start tomorrow, but it always takes a little bit longer. But we basically, we have one of the key hurdles is always really getting the commitment from our industry partner and having these contract signs, but we are very close. We are basically ready to sign this. So that's the first step, which is great. And we have a commitment that the virus will be provided for this trial, also in the international context. And then we starting, and actually tomorrow, we will have the first submission to our scientific committee. These trials need to be evaluated. So if everything goes well and there's no major discussion with our institutional review boards or with the FDA, which I don't anticipate, but you never know until we get all the approvals in place. I'm hoping that we could start either Q4 of this year or early next year, but the protocol is ready to go. The contract is ready to go. So now it's basically continuing to apply for grants for this, because as you can imagine, this is quite an expensive trial. We have an initial gift that really will help us to get it started, but obviously ongoing fundraising, getting the protocol approved by the different regulatory bodies, and then the contract as a key step is pretty much ready for signature. Any other questions, Javad?
I think we can, the other questions we can come back to at the end of your presentation.
Great, thank you. And then just to highlight some other work we are doing as part of this, the DMG Act group, and this is really based on wonderful work from Dr. Okada, and the team who is leading this clinical trial is Dr. Marie Jäger-Krause and William Temple, both really interested in moving sort of other immunotherapy approaches forward. And this is a study that hopefully will also start either end of this year or early next year. It's a phase 1 study of BCAN SynNotch CAR T cells. Just in the interest of time, I will just briefly show that this is basically sort of a adapt SynNotch CAR T therapy for DMH. So through extensive antigen screening, the group identified BCAN as a proteoglycan localized to the neural and glial surface as a promising priming antigen for this type of strategy with the SynNotch therapy, and basically using this sort of as a catch to then only activate basically these CAR T cells when both of these are present. So you basically have to detect BCAN, and then local killing then occur if you have a FA2 or the IL-13. And what we are going to move forward based on these wonderful preclinical data, and they have also been presented, so I don't go in great detail, but what you can see here that obviously sort of the dual B-Sync strategy led to 100% survival in these mice if given intraventricular, which is now a really common and accepted administration for any type of cellular therapy. And so this is basically, we will have 2 stratum. This trial has been discussed already with the FDA. So newly diagnosed patients, you will undergo leukapheresis, as you have to go for many of these CAR T cell products or cellular products. And then we will either go directly into an intraventricular administration. If we are giving them intravenously, we will first have lymphodepletion, then IV, and then we will follow this up with monthly ICV. There's still a lot of discussions in the field about what is the right combination. Is it really that you should combine lymphodepletion, intravenous administration, and ICV, or like some other strategy that mainly is really pursued also in Seattle, mainly only ICV? And I think that there's a lot of discussion, and hopefully over the next years we will learn. But this is another sort of strategy that was developed and was also informed by, for example, the tissue microarray that Javad introduced earlier to ensure that obviously these antigens are present really in the majority of diffuse midline gliomas. Carl, do you want to take this slide?
So this is work. I mean, I think this actually comes from communicating with families who are often placed with the experience either in the upfront setting or the recurrent setting of saying, we're excited about ONC201 or ONC206, we're excited about CAR T, and it's kind of, how do we decide which direction we want to go? And so Nick Vitanza, who many of you know, helps coordinate a lot of the CAR T trials out of Seattle, but also is involved in our DMG Act working group on the preclinical side and running a lab that studies CAR Ts, just took that to his cells and mice and added CAR T for his B7H3 as well as ONC206. And what he did here, which is kind of interesting, is he actually decreased down the ONC206 dose to the amount that it would not suppress the T cells and layer them on top of each other. So this data is fresh as of, you know, just earlier this week. He presented at a conference, and so not yet public knowledge, but we were excited to see from this work that combination of sort of even reduced dose ONC206 along with the CAR T did have combinatorial benefit in these mice. So this is future work. Again, to Sabine's point, we're not sure if the best way to do this is to layer, you know, promising therapies on top of each other or do them sequentially. And so we'll be working on this.
Yeah, thank you. Thank you, Carl. And so when we also pulled sort of really key thought leaders in diffuse midline glioma research and translation, sort of the key areas that came out is really thinking about effective implementation of combination therapies, that this is really still a key issue we should tackle. And then also, what is a good endpoint? And I think this is still something the community is struggling with, right? In terms of, can we use objective response? Can we use progression-free survival and overall survival? And just in recent discussion with the regulatory agencies, right now, we can only really use as an approved endpoint in our study overall survival. But as we're starting to see little progress with each of our different therapies we are pursuing, and we discussed some of the metabolic agent and targeted agents that we are pursuing within PNOC, and obviously some of the immunotherapy approaches, but there are obviously others. And often children go from different trials to different trials. We are losing a little bit to really understand the impact one specific therapy has on the outcome of our patients. And so we really need to think about how can we integrate also more innovative biomarkers in making a decision if it would be best for a patient to switch to another therapy or not. And so, Carl, you have done some wonderful work trying to develop also new imaging markers. So maybe you can just walk the audience through that slide.
Yeah, one of the things that's interesting when you look at when patients get MRIs, all of our metrics of whether the tumor is growing is really still based on two-dimensional size. And I think everyone in the clinical community knows that that's not a great representation of what's happening with the tumor. And so there's a lot of ways in which this is moving, a lot of which involve radiologists and radiology researchers within the PNOC DMG working group who do advanced genomics and AI. But a more simple approach that one of the researchers here at U of M is taking with me is to look at some of the imaging that's already captured. This is diffusion imaging. It's part of standard of care. It really tells you whether the tumor is dense or not. And what we know from other studies is that high ADC means tumors are less dense and possibly dying from response. And we were surprised to see when we look back at patients who got ONC201, this is all data from prior to PNOC 22, so phase 1 and expanded access data, that those tumors at cycle 3 that showed that sort of high ADC, a little bit less dense tumor, those patients went on to do better in terms of overall outcomes and overall survival. So what we're going to do now is see if this is validated in this PNOC 22, which is going to be much larger number of MRIs as well as lots of international cohorts. Here's an example of a patient who at about 6 months from therapy on ONC201 had a reduction in the size. That's the dotted gray line if you're following that really complex graph in the middle. And the clinicians and I were thinking the tumor was responding, but actually what was happening, if you look at the red and the blue, that drop in red tells us that the tumor is actually getting much more dense and cellular, and that's a bad sign that the tumor is about to grow, and that's what we saw. So we also see this in tumor DNA, and so what we really want to do, and we'll have the data with PNOC 22 to validate this, is to look at both imaging, advanced imaging, and the liquid biomarkers.
Sorry, I couldn't unmute myself for a second. So, and based on what Carl showed, we have also, which we don't have time to get into, but we have also really a large group of people specifically pulling all of the data we have on children, young adults with diffuse midline glioma. And this includes a lot of the PNOC data, but also data from different institutions, including our DMG center in Zurich, including University of Michigan, Utah, and Dana-Farber, as well as Stanford. And we are collecting on these patients all the longitudinal imaging. We are collecting the molecular features. And that cohort of imaging is now currently being analyzed using sort of automated segmentation tools to really define the tumor volume. And then hopefully we can use this data set to also answer some additional questions. But just in the interest of time, we will finish up here shortly how we are within DMG really see sort of where the field needs to move. So currently how many of these clinical trials are currently being designed is basically we are testing one specific strategy and we are looking at toxicity and we are looking at benefit. So many of the CAR T-cell trials, that's exactly what we are doing. The initial phase 1 study of the oncolytic virus, but also our new arm within the DMG platform trial is looking sort of at these single sort of therapies within that context. And then we often treat our children until either there's progression, and we understand that unfortunately the tumor is not responding anymore, or if a child experiences too much toxicity. And just recently we had our large investigator meeting, but also the workshop at the University of Michigan. And I think we are all very excited, and I think the field is really ready for it, where we are trying now moving away from this multi or single therapy investigation to really this multi-modality clinical trial design, where we are really trying to reiterate around using radiation therapy, obviously a standard of care, and thinking about a combination of a short course and not until progression or toxicity, but really a defined course of potentially application of cellular therapies, just as the CAR T-cell therapies, maybe with and without of targeted therapies, depending on the preclinical data, following this with potentially oncolytic virus, and maybe the generation of vaccines that then will allow us to maintenance it, and then cycle this. Because for many other solid tumors we are treating within pediatric oncology, we are not just sticking to one modality, we are really recycling, reiterating around different therapies we are integrating. And so really we came together as a group and will hopefully have a workshop where we really bring in all the different expertise and trying to design this, because I do think we now have enough sufficient data from some of these really single therapy trials that we now can integrate this. And obviously with the help from our preclinical scientists, we are then leveraging all the wonderful correlative studies we have now integrated and learned how we can successfully implement the collection and analysis of these within an international context, and will hopefully help us to basically decide when a patient should be switched, exactly what Carl just mentioned. So with that, we are coming to an end here. Javad, do you want to take the last few slides?
Yes, this is representative of some of the funding that we have received, the peer-reviewed, typically government funding that we have received. You can see the NIH, the Swiss National Science Foundation, Department of Defense, the EU Horizon, and many other peer-reviewed funding that we have received. And this is really an indicative of the support that you foundations have given to us. Most of the work that we presented here has been the work that could not have been funded by large institutions or by government. No one would fund us to just do drug screening or look at the correlative specimens. But the funding that from all of the foundations that are listed here, thank you to all of you, thank you to your children who have given us the specimen, the data to analyze. And you can see collectively the DMG Act has been very successful to secure over $15 million of funding across all of the sites. Thank you. Oh, and this is the last meeting that we had. So we've had 2 in-person meetings. The first one was in Zurich, post-COVID, of course. And the second one last year, this one was in Madrid. We tried to get together, I think, is more effective. We do also meet in the context of PNOC, which most of us did last week. And we also try to have DMG Act specific meetings as well.
Great. So with that, I will stop sharing and happy to take.
Yes, there are a couple of questions, Sabine. So from Patrick, maybe we can start from bottom. When will initial ONC206 efficacy data from PNOC 023 be published?
Oh, great. That's a good question. So ONC206, also we are very excited about. It looks very promising in our preclinical studies. We started the trial with pretty low dose levels, and we are doing more or less real-time PK assessment based on the different dose level and then escalate as needed. So my sense from the current data, so we are still in the phase 1 dose escalation part, but I think we are getting close. The problem is obviously that enrollment is a little bit slower because we can only open up 3 slots at any given time, and then each patient needs to be monitored, which unfortunately takes a little bit of time. But I think we are close, and I'm hoping that we have completed at least the phase 1 and have a recommended phase 2 dose by the end of the year. And then we would publish most likely on that data, and then we will go into expansion cohorts to really understand the impact on efficacy. But we are still in this dose escalation phase. We are trying to understand what is the dose children can tolerate and what is really needed to achieve the concentrations in the brain tissue that we sort of anticipate is needed to have an effect. And this is based on a lot of PK modeling based on in vivo data, but also from the human data.
And Sabine, do you know the availability of the CAR T for Europe and the date potentially if it's planned?
So in Europe, there are now few CAR T cells open, if that's sort of a question. There's a trial open in the UK, but mainly for, I think, really children who live in the UK. There's an exciting CAR T cell study also run in Italy by Professor Locatelli, and I think that started enrolling also children with DIPG. There are a few trials also in collaboration with London and the Princess Maxima looking at B7H3 that will open soon. So I think that there is movement, that these trials with cellular therapies are also currently actively enrolling or soon to be activated also in Europe.
Okay, and when will the preliminary data be available for those expansion cohorts?
From which trial did it say?
I think it's from Patrick. I think this is PNOC 22 cohort 3201 with Paxilosib.
Yeah, I mean, we presented the overall survival data. So, this data I showed you, right, how the overall survival currently looks. We are working on the manuscript. And then obviously we have the expansion cohort, the specific in cohort 4, we are looking at different PK, but that was mainly designed really to make sure we are dosing this correctly. And then we are very early on in the combination strategies with ONC201 and these other different inhibitors, so that will take a while.
And will the compassionate use program be adapted for young children in case you find underdosing?
That is a good discussion that is out of my control, but that is my assumption. Yes. Yeah.
Okay, and I think we answered oncolytic virus for the recurrent.
There's some questions. This is my problem. There's some questions about the microbiome in terms of intervention, safety, biomarkers, how to start thinking about that, and
Yeah.
where we are in terms of the microbiome.
Yeah, I think that's a great question. And I think I'm personally very excited about this field. And I think there are different mechanisms how you can really change the microbiome. There is a lot of investigation. We are actually working with a really a great team also in Israel who is trying to see how can we modulate the microbiome. There's obviously fecal transplant that we have used in other disease settings. So I think there's a lot we will learn, but we first really need to take the step. What is it that really predicts potentially in terms of the microbiome, the outcome? And once we understand that, then we can hopefully manage to alter the microbiome. But in general, I would say that this is a pretty safe, intervention. And I think there's a lot of data supporting sort of this brain-gut axis interaction that we could potentially harness, not only really to improve outcome, but also to mitigate some of the side effects we are seeing. So because we know that modulating the microbiome can also alleviate some of the side effects we saw in the initial combination with ONC201 and paxilocin.
And Sabine, do we know that if the oncolytic virus that is being injected, does it get cleared by immune system after the first injection?
We don't think so, because it's also directly injected in the tumor. So we don't think so. Yeah.
I think one of the advantages of the design is that you're going to get a second biopsy in cycle. So you'll be able to look at the microenvironment as a consequence. And that'll be very powerful data to specifically answer that question, I think. So.
And I think there was a question also if the oncolytic virus arm will be open also in Europe, and that's definitely the plan. It will open in Zurich, in the Netherlands, as well as in Spain. And then I think the other big discussion is, which I don't think I answered totally corrected, right, is some of the immunotherapy trials and cellular therapy trials we are opening within PNOC, will they be also available in Europe? And we had a really wonderful discussion at our PNOC meeting just last week around us. So we had experts really who are dealing with the manufacturing of these cellular products from Australia, also from the Netherlands, as well as from the US. And as many of you are aware, there are quite substantial hurdles in terms of thinking about the manufacturing of these cellular therapies, in a multi-institutional setting, so just within the US, but also when you think about this in the international context. But there's great efforts and great energy, I would say, right now, where we are trying to move these therapies really from these single institutional settings really into a broader multi-institutional setting. And there are some already successful sort of studies that are doing this right now. And so we are trying to build on this. But part of it is obviously sort of leveraging existing infrastructure, but then also building up centers within the different countries who then can basically take on the manufacturing. And then these manufacturing are still very, very costly. So like just when we sort of compared prices in the different countries, it ranges really between 80,000 to 100,000 per patient for one cellular product. So that remains a significant hurdle if you think, obviously, you want to enroll many, many children. But it's something we are really thinking about, pushing how we can go away from these single institution studies to really have this a more multi-institutional setting.
Thank you. Carl, there's a question for you about ADC and tumor heterogeneity and how the ADC actually being affected by.
Yeah, it's a great question. So somebody knows their radiology because ADC, the simplest way you can do it is a box around the whole tumor and get a single value. And I think to this question's point, that's not how tumors look. There are areas of density and areas of lack of density. And so the ways in which we're addressing this is one is the one box, comparing that to multi-point, we call that voxel comparisons. And not surprising, when you have voxel values that you can change over time, that's actually much better at predicting. The problem is that has to be extremely centralized, that kind of level of advanced radiology imaging. So I think the question is, if that is the best metric, how do we move to a situation where the radiology interpretation can be done more in a sort of immediate way for the clinician, for the researcher, maybe through AI or something like that. But it's a great question about the heterogeneity, which we know is there.
And Sabine, PNOC 22 cohort 3 onc and paxilosib. There's a question whether or not this will be open in Zurich again.
Yeah, so that's a great question. So the reason why this is currently closed is because we started to see in a subset of patients some more severe side effects, and mainly really looking at sort of skin findings, but also, for example, inflammation of your bowel. And so right now, what we are currently looking at is, are there certain predictors that could tell us who are the patients who will potentially have that more severe side effect? And that is currently ongoing. We are thinking there might be a potentially genetic predisposition. So we are looking at the HLA composition of these patients, because that is often associated with sort of more severe sort of immune therapy type of side effects. So that is currently ongoing. And we're also looking at specific pharmacogenomics alteration. Could they influence why some of these patients have more side effects than others? And so once we understand that, and if we understand who might be some of the patients with a better response to that combination therapy, we could rethink about opening up by just defining more specific eligibility criteria. So for now, it's on hold until this analysis is completed.
Great. We have answered all of the questions that were in the chat. If there are other questions that people would like to ask, please either put it in the chat or ask directly.
Great. I also think we are at the hour for our meeting. So I know people start their busy day, at least in the West Coast. So Adam, I don't know if you have any closing remarks, but for my end, definitely wanted to thank all my wonderful colleagues, and really big shout out to all the investigators that participate in DMG ACT, and especially also to Javad and Carl. It has been really a great experience, and I'm really excited about moving this multimodality therapy forward. I think there will be some regulatory hurdles we will need to overcome, but I think we are very motivated. I know this is really what a lot of families are asking for. They don't want to have to decide between one strategy versus the other. They really want their children to get sort of the opportunity to participate in both. And so we will work very hard over the next few years to try to implement this. But also from a foundation, from a parent side, let us know if you want to be engaged. We are always very excited and open to work with our families. And some of the work we are showing today is really also driven by a lot of our families. I mean, this whole analysis, especially from the microbiome, was really spearheaded by some of our families. So really thank you for this wonderful partnership over the years. And we are looking forward to continue to work with all of you.
Yeah, no, I mean, I think the only thing I would add there is just to echo what Sabine said, that the work this team is doing wouldn't be possible without the people on this call. Your donations, your support, everything you've done, we're greatly appreciative of it. So thank you. If you have any other questions, please follow up with the foundation. We can forward them along to the doctors. Whatever you need, we're here for you. So we appreciate you all very much and thank you for being here today.
And just one last comment to address Aaron's question. Aaron, we do have, as a part of DMG Act, we do have annual updates, but also PNOC has annual updates to the families and foundations. I don't think the next one is scheduled, but Adam will reach out when the next one is scheduled. But we typically have 2 updates every year. One is through the DMG Act and one is through the PNOC.
And we will be having next Monday at the same time, 8 o'clock Pacific, 11 o'clock Eastern, the general PNOC spring meeting update. So it won't be DMG specific. It'll be touching on all tumor types and research happening, but please, if you're able, join us there. And if you haven't gotten the email to register for that, please reach out and we can make sure to get you on that list as well.
Great. Thank you, everyone. Bye.